Good evening. My name is Dr. David Doman, and welcome to another edition of Housecall. What's new with the George Washington University Cancer Center? Find out more right now. My guest this evening is Dr. Eduardo Sotomayor, Director of the George Washington University Cancer Center. Dr. Sotomayor, welcome to Housecall.
Thank you for having me.
So briefly, tell our viewers about your professional background.
I am a medical oncologist, but also I am a cancer researcher. Is what is called a physician scientist. Mm-hmm. So I see patients with cancer, in particularly patients with blood cancers, but also I have my own lab research team in which we are conducting investigations to find new treatment for patients with blood cancers.
Very nice. And where did you train? Where did you get your degrees?
So my medical degree, I obtained it in Lima, Peru, but then I moved to the United States, and in the late 80s, early 90s, I went to work in research in an area that at that time was probably not well known. It was the field of cancer, immunology, immunotherapy. So I worked in the lab, and then after that I went to do my training in internal medicine at Jackson Memorial Hospital in Miami, Florida, followed by fellowship at Johns Hopkins University.
Okay. In hematology oncology?
In hematology oncology, correct.
Nice. So briefly, of course, George Washington, where I have my own faculty appointment, for years they had an oncology division. Mm-hmm. What led to creating a separate cancer center? What was the rationale for that?
That's a very good question. I would say that the senior leaders at the university, the School of Medicine, the School of Public Health, the hospital, as well as the practice, which is the medical faculty associates, decided around 2014 to expand cancer beyond the division of hematology oncology, to expand into surgical oncology, radiation oncology, but also into the basic science. So what type of new discoveries George Washington University can contribute to the cancer field as a whole. In addition to that, so there was interest in getting involved in cancer control prevention, but also in community outreach and engagement. So therefore, the vision was to create a new entity, the GW Cancer Center, that will be the umbrella for all cancer-related activities, basic, clinical, population sciences, policy, education and training. All these activities will be under the umbrella of the GW Cancer Center. So, there was a national search, and at that time I was the chair of the Department of Hematology Oncology at Moffitt Cancer Center in Florida, a big cancer center, NCI designated cancer center, and I was attracted to Washington because I saw the potential, I saw the energy, and I saw the enthusiasm to try to develop a new innovative cancer center here in the nation's capital.
Very nice, very nice. So there's a real interdisciplinary collaboration now.
Correct.
Between all the specialties that deal with cancer.
So correct. So and what impressed me the most when I came here in 2015 is the quality of the people that were already here. Mm-hmm. Good basic scientists, exceptional clinicians, good cancer surgeons, population scientists, educators, but there were sort of island, everybody was doing a good job. So my job was to become the glue to bring them all together.
Right.
And in addition to that, identify our strengths and then make investment. And in 4 years, we have been able to recruit almost 40 new faculty.
Excellent.
From basic scientists, clinical population scientists to this new GW Cancer Center.
If an individual in our community is told by a doctor they have cancer, that clearly is a life-altering event. what sort of questions should a patient ask themselves about what the next step will be? Where should they go? What kind of questions should they be asking?
So the first thing, and I always tell this to my cancer patient, is number one is diagnosis, number two is diagnosis, number three is diagnosis. So that the days in which we just talk about lung cancer, those days are all gone. Now we know that lung cancer are several subsets of molecularly defined lung cancer. And let me just explain to you, molecularly defined. There are lung cancer that have alteration of a gene called EGFR or KRAS or PD-L1 overexpression. So now these days, just having a diagnosis of lung cancer is not enough. Is this a small cell lung cancer? Is this a non-small cell lung cancer? Does this cancer has this specific alteration? Because it is important to know, because now we have treatments that are directed against those specific abnormalities and treatment that works. So therefore, I will recommend to any person that has been recently diagnosed with cancer to ask those questions. Is my disease, just the disease that I treat is lymphomas? Well, there are more than 70 subtypes of lymphomas, and there are B-cell lymphomas, there are T-cell lymphomas, and within the B-cell lymphoma, there are one subtype that has been studied for the last 25 years called mantle cell lymphoma. So therefore, my first advice is we need to be 100% sure about the diagnosis. And that will require sometimes that our colleagues in the community will refer patients to a specialized center that sees 100 or many of those specific type of lymphomas. Or sometimes if the diagnosis is not, is challenging, so the biopsy slide can be sent to another institution that see large number of patients for confirmation of the diagnosis, but also to start doing those studies in order to identify more targeted what type of or subtype of cancer we are dealing with.
So what had been the standard of care until, let's say, 10 years ago, which is just to get a tissue biopsy confirmation and categorize it as lung cancer, colon cancer, breast cancer, etc., in 2019, 2020 is no longer adequate. You have to stratify the patient.
Correct. But this is true for some type of cancers, and we are making advances in other type of cancer. So for instance, just to give you an example, a couple of years ago, the FDA approved for the first time a treatment that is tissue agnostic. What does this mean? That in the past, when a patient will come to us, we said, okay, you have prostate cancer, you are going to see a prostate cancer specialist. Or lymphoma, you are going to see a lymphoma specialist or a colon cancer specialist. So this day, we know that these different cancers coming from different anatomical sites share a molecular abnormality. And now we know that those cancers that share this molecular abnormality will respond to a treatment that is called immunotherapy with checkpoint blockade antibodies. So there is a small percent, so we all know that pancreatic cancer is still a challenging disease, it's a bad disease, but there is a few percent of patients with pancreatic cancer that will have this molecular abnormality that could benefit with this treatment. Similar with colorectal cancer and similar with, so therefore when a patient is diagnosed, the patient needs to know or needs to be explained about all the advances that we have made in the last 10 years.
So if a patient is referred to your center, what happens at that point? Do they see one type of specialist, or is the case reviewed by a team of different collaborative physicians?
So in centers like us, as well as other cancer centers, NCI designated cancer centers, so we are not yet an NCI designated cancer center, but that's one of their goals, and that's the reason why I was recruited, is to take the GW Cancer Center towards the process of NCI designation. But in all these centers, we have what is
NCI
called is National Cancer Institute Designated Cancer Center. And the goal is to create multidisciplinary teams. So before we establish the GW Cancer Center, a patient will come to us to see a urologist who will make the diagnosis of prostate cancer, and then he will refer the patient to radiation oncology for consult or to a medical oncologist for treatment. But that means that the patient is moving from one office to the next to the next. So this day we have a multidisciplinary clinic in which we bring all the experts and the specialists to one place.
Right.
So therefore the patient will go to that place, and then it will be seen on the same day by a surgeon, radiation oncologist is needed, and medical oncologist is needed. So that facilitates the patient's experience, but also, we put our brains together and design a plan. What is the best treatment for this patient that we are seeing, all of us right now in this room?
So when a patient is seen, do you have like a collaborative team meeting, a panel to discuss the particular
Exactly.
patient?
So that is called multidisciplinary approach. We have that in breast cancer clinic. We have that in GU, genitourinary malignancies. We have our own lymphoma clinic, and so on. And the same in lung cancer. But also we discuss the new advances. So let's make sure that this patient with lung cancer has all the molecular studies that are needed, because those studies are going to guide our treatment. Does the tumor express high levels, low levels of this molecule, just to mention PD-L1, because now we have a treatment that is directed against that PD-L1 or PD-1 that is expressed in the tumor and the immune cells. So immunotherapy is an area that has advanced significantly in the last 20 years. And I am happy that I was among the few that believe in that field on the late 80s, early 90s.
You mentioned immunotherapy, and I know one of the hot topics now is malignant melanoma.
Correct.
And President Jimmy Carter, unfortunately, had metastatic melanoma to his brain, and I think the media and the public was ready to write him off.
Correct.
And yet, after immunotherapy, he seems to be doing quite well.
That is correct. So to put this perspective, and you mentioned melanoma, I always tell my fellows, so the best cancer is the cancer that you don't have, or the cancer that was prevented properly, right? So you get melanoma because of sun exposure. So this is, so again, education, prevention. So be careful about sun exposure, otherwise you can develop melanoma. The same is true with smoking. If you smoke, you're going to have increased the risk for several types of cancer, not only lung cancer. So going back then to melanoma, so for many years the treatment was just chemotherapy, but there were there was data suggesting that melanoma is an immunogenic tumor, which means that can be seen by the immune system. This is a study from Steve Rosenberg from many years at NCI. And then, so there was major discoveries that if you properly harness the immune system can do the job. But this is the problem that we had years ago. So we thought that we were really smart, and we said, let's push the accelerator, let's stimulate the immune system, and then the immune system will take care of cancer. Well, we failed. Until several scientists say, so instead of pushing the accelerator, what about if we start to release the brakes? And the brakes were identified, CTLA-4, PD-L1, and now we have treatment against those brakes. And blocking those brakes actually works. And you mentioned the example of President Jimmy Carter. If he would have been diagnosed with metastatic melanoma to the brain, I would say probably 10 years ago, he will not be with us right now. Yeah. But he was diagnosed when we have that treatment available. And
I'm going to ask you to hold the thought. We're going to pause briefly for a public service announcement. More with our guest, Dr. Eduardo Sotomayor, Director of the GW Cancer Center. We'll be right back.
150 over 90.
180 over 111.
160 over 110. I had a stroke.
This is what high blood pressure looks like. You might not feel its symptoms, but the results from a stroke are far from invisible or silent. If you've come off your treatment plan, get back on it, or talk with your doctor to create an exercise, diet, and medication plan that works for you. Go to loweryourhbp.org.
If I would have followed a treatment plan, I would not be in this situation.
We're back. My guest this evening is Dr. Eduardo Sotomayor, director of the George Washington University Cancer Center. Dr. Sotomayor, we were discussing metastatic melanoma and some of the immune breakthroughs there. But there's also been some very interesting breakthroughs in terms of other cutting-edge therapies. Give our viewers an overview of some of those cutting-edge therapies.
So the other area that we are very excited in cancer treatment is what we call target therapy. And this is based on the knowledge that we have gained in the last, I would say, 10 to 20 years, knowing better about what is wrong with the cancer cells and what pathways or molecules or proteins the cancer cell is using to survive longer, to be resistant to treatment, to chemotherapy. So this knowledge allow us to identify, so for instance, there is, in the case of lymphoma, there is one target that is called BTK, Bruton tyrosine kinase, that the malignant cells require for their survival, proliferation, and to be aggressive. Well, there is a drug that is going to block that particular protein, and that is what we call target therapy. It works. It's changing the way that we treat some of the lymphomas, in particularly chronic lymphocytic leukemia. Now we have plenty of examples of this target therapy against BRAF mutations, against KRAF, against HER2/neu in breast cancer. So I keep going and going. And so they work as a single agent, so we use alone. But now what we are doing is, what about if we combine this target therapy among themselves? What about if we combine this target therapy with chemotherapy? What about if we combine this target therapy with immunotherapy? Right. But that also creates a challenge to us, because we have several drugs, and then how we are going to predict which combination is going to do the best, right? And we are I think we have so many of these drugs that we are not going to be able to do large phase 3 clinical trials like we did in the past. I mean, still we need those phase 3 clinical trials, but now we are becoming smarter in defining better clinical trials to combine two drugs. And again, that's going back to the basis, looking at the malignant cell and see if we attack this target, then the malignant B cell is going to use a different pathways, and therefore we said, okay, now we can combine this drug that blocks this pathway with this drug that blocks the other pathway, and we are seeing some progress in that area. For instance, going back to this BTK inhibitor, block one pathway, but then there is another drug that blocks a different pathway called BCL2. You combine the two of them in the lab, in preclinical models, it works, takes to clinical trials, also works indeed. So like I think the future is I am very excited about the future.
Sounds like a big chess game with the cancer.
Correct.
Now, because you're giving very targeted therapy to, if you will, starve the cancer.
Correct.
Do you find that there is less side effects then for the patient?
That is a very good question. I think that when we educate our patients, so we don't say to the patient, okay, actually the other thing about some of these target therapies is that they are pills. Mm-hmm. So they are not, that you have to go to the doctor's office, receive them, be sitting down in the chair, receive an infusion for 1 hour, 2 hours.
Sure.
These are pills. But we don't tell the patients, take these pills and see you in 1 month. Mm-hmm. It doesn't work that way, because these pills have their own set of side effects. For instance, the drug that I just mentioned before, the BTK inhibitor, can increase the blood pressure, can induce easy bruising, can produce bleeding in some patients. Mm-hmm. So there are other drugs that are associated with bad, gastrointestinal symptoms, other drugs that are associated with skin rashes. So we need to educate our patients about the different set of side effects that they are going to experience with this so-called target therapy. Although we would like to have the ideal drug, as you mentioned, will be a target therapy, no side effect. That doesn't exist.
Not yet.
Not yet, correct.
Let's go on to discuss a very interesting category of diagnostic test that is now in the medical literature called a liquid biopsy. Explain to our viewers what that concept is and how you're already utilizing it in your cancer center.
Very good. It's a very good question. For the first diagnosis, and let me make clear, we always want to have tissue. And we will get the tissue either, sometimes it's very accessible, or sometimes the patient will need to have a robotic surgery to get a piece of the tissue for the first one. So with that one, we are going to make the proper diagnosis, what type of cancer, subtype, molecular subtype, and also we are going to learn about what is wrong with that cancer cell. So then we design a treatment. So now what we know is that some of the tumor cells that, let's say, were in the lung, some of them are going to escape to the blood. And that we are going to call them circulating tumor cells. And we can follow those cells. It's not an easy technology, but technology is getting better and better, right? And of course, if you have more circulating tumor cells, you have more tumor burden, right? So that's, but also you can start your treatment, the circulating tumor cells disappear. We are all excited, PET scan, CAT scan,
Sure.
no CTC, we are all happy. And then you start to follow your patient, and then 3 months later, 4 months later, you start to see, hey, circulating tumor cells are coming back. You do a CAT scan, you don't see yet any mass in the lungs, but you know that the disease is coming back. So that with circulating tumor cells. But then someone said, what about, can we just follow the DNA, tumor DNA in your blood? And that's these two, the circulating tumor cells and the tumor DNA, are two examples of liquid biopsy. So our colleagues treating solid tumors, I think they are ahead of us. I treat blood cancers, they are ahead of us in using this liquid biopsy. So the other example that I need to give you is when we look at primary tumor, the tumor that we obtained during the initial diagnosis. So we are going to do this day what is called next generation sequencing that is going to allow us to see what abnormalities this tumor has. And we can follow those abnormalities, not in all the cancer, but in some cancers in the peripheral blood. So why is this important? Because number one is going to allow us to monitor response to treatment. So number two is going to allow us to have early detection that the tumor is coming back. So number three, we start to see a different type of abnormality. So we see, okay, now the tumor is evolving. It's becoming more resistant to this treatment. So perhaps it's time to add a second treatment or a totally different treatment. So in the past, before we had the liquid biopsies, sometimes we have to repeat biopsies, right? And that created a lot of, it was difficult to achieve. So the other important benefit of liquid biopsy is when we perform clinical trials, right? So if the patient had a rapid response to the treatment, how long is the response being maintained? And of course, it's easy to obtain blood every week or once a month or every 3 months that do repeated biopsies. So those are some of the many benefits that we are seeing with liquid biopsies.
Now you mentioned clinical trials.
Yes.
Explain to our viewers what exactly is a clinical trial as opposed to conventional therapy,
Good.
and when should a patient be considered for a clinical trial?
So let me just emphasize the conventional treatment that you refer were the clinical trials of the past. So this drug, going back to this BTK inhibitor that we are using, and in some type of cancer is changing the natural history of the cancer, chronic lymphocytic leukemia, BTK inhibitors. It started with a phase 1 clinical trial, and then to a phase 2 clinical trial, and then to a phase 3 clinical trial.
Explain to our viewers
So
what
let
you
me
mean by the
explain to that.
phases.
So phase 1 clinical trial is when science has shown that there is a good target, BTK. And then investigators found, or pharmaceutical companies find a drug that attack that target. So a lower dose, nanomolar range, very low dose, affect that target. So then animal studies are going to be performed, although animal studies not always predict what is going to happen in humans, correct? But in any case, so the drug works in vitro, has a good safety profile. I mean, there is a process to identify toxicities, and then the drug is taken for the first time into patients. That's a phase 1 clinical trial. What we want to learn is it is safe, and can we increase the dose? So we start with a lower dose, no side effects, then we move to the next step until we find that the drug is causing toxicities. That's a phase 1. So sometimes we see fantastic results, right? And that encourages physicians, but also patients, to move this into a phase 2 clinical trial. And in phase 2, what we are looking is just beyond safety, so we want to know whether there is efficacy. Mm-hmm. It's going to work in patients with B-cell lymphoma. It's going to work in patients with, with CLL, with chronic lymphocytic leukemia, or lung cancer, and so on. And then, traditionally, so that drug will be taken, if it works, it will be taken and compared head-to-head with whatever is the standard of care for that particular disease. That's a phase 3 that requires a large number of patients. So there are situations in which we have what we call orphan cancers, orphan diseases. And there has been, and the lymphoma that I have been treating for many years, mantle cell lymphoma, is one of those. And there has been pills that have been shown to work for this type of lymphoma, and the results were quite appealing, that the drug has been approved by the FDA just based on phase 2 data. So these are the steps. So the other good news for patients is that before, it took many, many years to move a concept from the lab, from the laboratory, to FDA approval, and that process is getting shorter without, and I will have to emphasize, without compromising safety of the patients.
If I can interject.
Sure.
We have 1 minute left.
Oh.
Tell our viewers briefly, what is a cancer survivor? You have 1 minute.
So I will respond that what my own experience. When I was a fellow, we defined cancer survivor, the cancer patient that went through my treatment. I will follow those patients for 1, 2, or 3 years, and sometimes 5 years, and then at some point I said, there is probably you are cured of your disease, you don't need to see him anymore, I'm going to transfer your care to a group of physicians that specializes in cancer survivors. So that was the old concept. The new concept is, we hope, and we are making significant strides in improving the outcomes of cancer patients, and therefore we want all our patients to be survivors from day 1. After diagnosis, as soon as we start treatment, we want to have our survivorship team meeting with our patients.
Dr. Sotomayor, thank you for joining us on Housecall.
Thank you very much. Thank you for having me.
My pleasure. If our viewers have any questions, how can they reach you?
Through our website, gwcancercenter.org, or through the phone number that you're going to see in the camera. Okay. They're going to be displayed.
Thank you so much.
Thank you. Yeah.
My thanks to Dr. Sotomayor for an excellent interview on the progress made in cancer. My thanks to my team here at the studio, and of course my thanks to you at home for watching our program. Let us know how we're doing. You can reach me at my practice website, montgomerygastro.com. As for our next show, it's going to be a very interesting one. I will have the president of the Montgomery County Medical Society, and he will be discussing healthcare issues both in Montgomery County as well as statewide throughout the state of Maryland. It's going to be a very interesting show. See you then next time for another edition of Housecall. Good evening.